హాయ్ ఫోక్స్, వెల్కమ్ టు మై ఛానల్ ది యావరేజ్ డర్మాడాక్. ఇక మొదలెడదామా? Cyclosporine. It is isolated from soil fungus called Tolypocladium inflatum cams. Available in capsules 25 mg, 100 mg, oral solution 100 mg per ml. Reaches peak within 2 to 4 hours. Bioavailability is 30 to 50%. 90% of plasma protein bound. T-half is 5 to 18 hours. Metabolized in liver via CYP3A4 enzyme and excreted via liver only, that is bile and through feces. Very least amount, that is 6%, is excreted through urine. Main mechanism of action is immunosuppression via calcineurin inhibition. If calcineurin gets inhibited, it leads to inhibition of nuclear factor of activated T cells, which leads to downregulation of inflammatory mediator interleukin 2. It inhibits T cells. T for interleukin 2, T for T cells. FDA producers are atopic dermatitis, psoriasis, which is severe, disabling, recalcitrant and resistant to treatment. Off-label users are immunobullous diseases, autoimmune connective tissue diseases, granulomatous diseases, neutrophilic dermatosis, chronic spontaneous urticaria, chronic actinic dermatitis, lichen planus, lichen planopilaris, and alopecia areata. Absolute contraindication is severe renal dysfunction, uncontrolled hypertension. Both are side effects of cyclosporine. So if already it is present, it is an absolute contraindication. Hypersensitivity for any drug and malignancies. Relative contraindications are pregnancy and lactation. It is a category C drug. Controlled hypertension, active infection, immunodeficiency states. If patient is already on immunosuppressive drugs like steroids, we should not. It is a relative contraindication to cyclosporine. Drug interactions. Enzyme inducers will reduce the levels of cyclosporine. Enzyme inhibitors will elevate the levels of cyclosporine. Adverse effects of cyclosporine. Remember like this: porine, urine, nephrotoxic drug. Because of this nephrotoxicity, there may be elevation in blood pressure, that is hypertension, hyperkalemia, hyperuricemia, hypomagnesemia, hepatotoxic at high doses, as it is metabolized in liver. If we give at high doses, it will be toxic to liver. Hyperlipidemia, hypertrichosis, hyperplasia, that is gingival hyperplasia. Coming to investigations and monitoring, from these adverse effects, we have seen that we have to give importance to nephrotoxicity and BP. So we will check CBC, LFT, RFT, fasting lipids, magnesium, potassium, uric acid, mainly blood pressure and serum creatinine. 2 times we will check a day apart. Then we will follow up bi-weekly for 2 months. Then monthly once. At every checkup we will check BP. If serum creatinine is elevated to more than 30% from that of the baseline, we will reduce the dose by 1 mg per kg for 1 month. Again we will check serum creatinine. If it is still above 30% of the baseline only, still persisting the same, then we will stop the drug. If it is elevated by 50% in the first visit itself, we will directly stop the drug. Remember the channel name. Don't forget to like, share and subscribe. Thank you. Hasta la vista. До свидания.